Hello and welcome to MK's Exam Secrets. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at exam questions in a clinical course. This is indeed Season 3, Episode 4, Pediatrics. Look out for 2 videos today coming out on Pediatrics. This is the first one, and the second one which will be coming out before midnight. That is obstetrics and gynecology. You already know the gist of these videos. If you haven't yet subscribed, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. You can pause the video before I actually give you the answer to think through the question. So beginning with our question 1. Mavuto is a 3-year-old and presents to the hospital after he convulsed twice at home. The convulsion lasted about 2 minutes and he became unresponsive afterwards. He had a history of fever for 3 days and has been less active and social than usual. His appetite has greatly reduced. His urine was like black tea in the morning. He has been previously well. With the first episode of this nature, when you try to examine him, he refuses and says he does not want you to touch him, looks at his mother and cries to take him home. He is febrile with a temperature of 38.8 degrees Celsius and appears very pale and moderately jaundiced. The rapid malaria test is positive. Question A. What is Mavuto's level of consciousness? What are the possible causes of convulsions in Mavuto? Then this question goes on and says the following hemogram was taken, WBC 19. They have even done you the favor of giving you the normal values here on the right. If it was up to me, I wouldn't have given you the normal values. Lymphocytes 9.36, monocytes 0.54, neutrophils 9.49, eosinophils 0.20, basophils 0.11, RBC 2.3, hemoglobin 4.9, hematocrit 15.4, MCV 67, MCH 17.2, MCHC 25.7, RDW 17.9, platelets 155. Part C. What is your diagnosis and why? How would you manage Mavuto? So you can actually pause the video and actually write down your answers. I hope you have been paused the videos. If you didn't pause the video, just rewind and pause it. As simple as that. So here comes the answer. So when you're assessing the level of consciousness on this child, there is a scale that's known as the Blantyre Coma scale. I know some of you are hearing this for the very first time. So this was actually named after the city Blantyre in Malawi, and it's actually a scale that is used to assess level of consciousness, especially in severe malaria. Now, if we look at this scale, it has pretty much 3 parameters. It's like your Glasgow Coma scale, but you can think of it for pediatrics children. So your eye opening, which is 0 when they're not directed, 1 if they're directed to eye movements. Your verbal response, 0 if there is no cry, 1 if there's an inappropriate cry or moan, then 2 appropriate cry. Then motor response is of course 0, it's non-specific, or there's no response at all. 1 if they withdraw to pain, 2 the localized pain. And remember that this child here, first of all, we look at the eye. They're opening their eyes, so they're able to direct their eye movement. So we can give them a score of 1. Then under the verbal here, they cry inappropriately. If someone touches you and you cry, that's rather inappropriate, don't you think so? An appropriate cry would be, for example, if the child is in pain or some sort, or you inflict some pain and they cry. So here there's an inappropriate cry, so we give them a score of 1. And of course, they're able to localize pain, so they're able to move, so we give them a score of 2. So this child is a score of 4 out of 5. So they still have some level of consciousness in this child. Now, what are the possible causes of convulsion in Mavuto? So it's most likely that this child may have cerebral malaria. Remember that our diagnosis for cerebral malaria is 2 or more generalized tonic-clonic convulsions in 24 hours attributed to no other cause but malaria. Alternatively, we can say an unarousable state attributed to no other cause but malaria. So this child could actually have cerebral malaria. Then, or you could even say severe malaria itself is a cause. Then this child could have a febrile convulsion. Okay, remember he still falls into the age bracket. Then once we do the hemogram and we find out that, okay, let's look at the hemogram and the abnormalities that are present here. So our WBC is very high, so about 19.7, or actually not even very high, slightly high. Our lymphocyte count is slightly high. Your monocytes are within the normal range. Your neutrophils are slightly high. Your eosinophils are within the normal range. Your basophils are within the normal range. RBC is very low. Hemoglobin is very, very low. Hematocrit is very low. MCV is within the normal range. MCH is low. MCHC is low. RDW is slightly high. And the platelets here are low, or rather normal. So this person has severe malaria. Now, why do I say severe malaria? They have features of course, your cerebral malaria, which is your convulsions 2 times a day. They have your black water fever, that black tea, like it's because of hemoglobinuria. They also have severe anemia. Of course, their HB is 4.9. And of course, this, I know some people are going to fight me in the comment section below, but I will redirect them to Medscape to actually look at the features of severe malaria in children. Jaundice is actually classified there. So how would you manage Mavuto? So you want to admit Mavuto to ICU. Start him on intravenous artesunate 2.4 milligrams per kg IV at 0, 12, and 24. Then afterwards we give it daily until he can take it orally. Then we transition him to Coartem. That's your artemether and lumefantrine, 1 tablet because he's 3 years. Then 1 tablet twice a day for 3 days. Then of course we should nurse him propped up, monitor his vitals, RBS profile, give him glucose if he's hypoglycemic, then cover him on broad spectrum antibiotics, cross match him and transfuse packed cells. You can also transfuse platelets because he's almost at the borderline. Give him intravenous paracetamol for the fever, open a fit shot, and if he convulses, diazepam 0.3 milligrams per kg if it's IV, 0.5 if it's rectal. That's how we're going to manage this child. Moving on to question number 2. Bupe, an 11-month-old girl, presents with 3-day history of watery diarrhea and vomiting. Her mother says she has been progressively becoming weak and refuses to breastfeed. She has also noticed Bupe has had a fever for the past 2 days. Her mother admits that she has not been taking Bupe for immunization due to long distance to the clinic. They drink untreated water from a well and use a pit latrine as their toilet at their home, at their house as a toilet. On examination, she is inactive and is unable to open her eyes or even cry, despite the mother trying to wake her up and the nurse pricking her finger to collect blood for malaria test. On examination, Bupe has sunken eyes, a dry mouth, and skin pinch that goes back in more than 2 seconds. She has cold hands and feet, weak thready pulse, and capillary refill time of more than 3 seconds. What is Bupe's coma scale? Classify Bupe's level of dehydration. What are the likely causes of diarrhea and vomiting in Bupe? What is your diagnosis? What would be Bupe's initial management? So as you can see, here I've introduced a new concept of level of consciousness in pediatrics. So I hope you'll learn something new from this video. If you have, please show some support, drop a comment or drop a like. It really helps in the dark abyss of the YouTube algorithm. So here comes the answer. So this child is not responding at all. Everything is 0. The eye opening, 0. They are not able to open their eyes. There's no response. Verbal, there's no cry at all. It's not even inappropriate. There's nothing. Motor response, there's nothing when you inflict pain. So they have a blunt eye coma scale of 0 to 5. So this child is pretty much almost unconscious. Actually, he is unconscious. Now, the fact that this child is unable to drink, they are unconscious, there are features of dehydration like a sunken mouth, a skin pinch that goes back more than 2 seconds, and of course a delayed capillary refill time and a weak thready pulse. Already these are features that are going to be pointing towards severe dehydration. Remember, dehydration is classified as no dehydration, some dehydration, and severe dehydration. We no longer want to use the mild, moderate, and severe. Now, the causes are most likely infectious in nature in this child because they're drinking tap water and they're using a pit latrine. So it's most likely viral because she missed her immunizations. That's very important. Especially the rotavirus vaccine. So rotavirus is one of the causes. You have also other viruses like adenovirus and even norovirus, as well as some bacterial causes like E. coli, Staph aureus. Remember, these are causing watery diarrhea. And we also don't want to rule out cholera. We could add that to the list, but they would present you with this typical characteristic rice water stool. So our diagnosis here will obviously be acute gastroenteritis because this child has both vomiting and watery diarrhea. Now, how do we manage this child? We're going to be using our WHO Plan C to rehydrate the child. That's very important. We admit the patient. We gain venous access. We start running our IV fluids. Our fluid of choice is either Ringer's lactate or half-strength Darus solution. If you don't have this, then you can use normal saline as a substitute. So you're going to be giving, remember this child is less than 1 year, so you're going to be running the fluids over 6 hours. If they were greater than a year, you should have been running them over 3 hours. So you're going to be giving 100 mils per kg of the fluid. 30 mils per kg you're going to be giving it in the first 1 hour. 70 mils per kg you're going to be giving it in the next 5 hours. If they were older than 1 year, you would say 30 mils per kg in 30 minutes, then 70 mils per kg in 2 hours, 30 minutes. We reassess this child every 15 minutes. If they're improving, we continue with the same treatment. If they're not, we increase the speed of the fluid. Then we reclassify their hydration status after 6 hours. Give them zinc sulfate because they're above 6 months. We give them 20 milligrams. If they were below, you'd give them 10 milligrams. 20 milligrams of zinc sulfate orally once a day for 10 to 14 days. We encourage the mother to continue breastfeeding, educate the mother on, of course, the features of dehydration, the worsening signs of dehydration. Deworm the child. If they're rehydrated, then you can transition them to your plan A, where you give fluids every time they have a loose stool. And of course, discharge them after that. Then question 3. A 6-year-old female is admitted to the pediatric ward with a 2-week history of alternating diarrhea, constipation, headaches, and body hotness that occurs mostly in the evening and at night. On admission, her body temperature is 39.1 degrees Celsius and her heart rate is 100 beats per minute. Her hemoglobin, or rather hemogram, is as follows: WBC 2.5, hemoglobin 8.4, hematocrit 40%, MCV 88 FL, that's femtoliters, platelet count is 100. What is your most likely diagnosis? What are the causative organisms? What investigations would you carry out? Name 5 systemic complications due to this condition. I know some people are going to jump on the bandwagon of the trap that this question has set on. And I'm sure you'll be able to identify yourself that you have been trapped in this kind of question. So here comes the answer. So this is a child that has alternating diarrhea and constipation. Whenever you see such a thing with a fever and you see that this person has a low platelet count, then you should think that this person has enteric fever or typhoid fever. Now remember that this is going to be caused by Salmonella typhi or Salmonella paratyphi, especially type A and type B. Remember, in the first week you can culture this from the blood. The second week you can culture it from the urine. The third week you can culture it from the stool. So you can add blood cultures, bone marrow cultures, which are much more specific, urine and stool cultures. You can also order for your C-reactive protein and a Wido test. You shouldn't repeat full blood count. It's already been given to you in the question. So name 5 systemic complications. Just know the inflammations. So it could be meningitis, encephalitis, coma, lobar pneumonias, myocarditis, splenic abscesses, cholecystitis, hepatitis, osteomyelitis, DIC, intestinal perforations, and acute abdomen. Most of the complications are usually seen in the 3rd week of the condition. Moving on to question 4. A 2-year-old toddler is brought to the pediatric emergency department with a 1-week history of progressive dyspnea and a non-productive cough, fever and chills. He is diagnosed with nasal flaring with chest recessions. The child was diagnosed with HIV 4 weeks and commenced on antiretroviral therapy. His baseline CD4 count was 13%. Mother believes the drugs are causing her son's current illness. If the mother's apprehension is true, what is your diagnosis? What is the most likely chest condition the boy is suffering from? Give 2 differentials. What do you think the CD4 count would be at this point in time as compared to the baseline, low or high? I know some people are going to fight me about this question. I am pretty adamant there's someone who's not going to understand the answer to this question. But anyways, write down your answer before I give you the answer. So here comes the answer. So this is obviously immune reconstitution syndrome. Remember that IRIS is a complication where you start someone on treatment of usually an opportunistic infection, or you give them your ART, your antiretroviral treatment, and then their immune system gets better. Then it starts now attacking these opportunistic infections that were hidden, so it starts unmasking them. Or indeed, you may even diagnose a new opportunistic infection. So this person has immune reconstitution syndrome, or IRIS. Then of course, most likely this child has a pneumocystis jirovecii pneumonia because of their HIV positive. They had a very low CD4 count. They were recently started on treatment. Of course, they have this progressive dyspnea and they have this cough. Do they have the cough? Yeah, non-productive cough. So our differentials, of course, would be TB as well as bacterial pneumonias. Now here's the catch. What do you think the CD4 count is going to be now if they have IRIS as compared to the baseline? So it would actually be high. Why? It's because of the underlying pathophysiology of IRIS. Remember that IRIS is due to the immune system, how the immune system is reacting to, for example, the opportunistic infections that were being collected, or the opportunistic infections that are masked. So this overwhelming response, the production of the pro-inflammatory markers, the production of the cytokines, is what is bringing on the symptoms and causing the patient to appear like as if they're deteriorating or they're worse. So the immune system has recovered and started now fighting. It's kind of like this. The immune system was sleeping, there were infections, and it was just watching the infections because it couldn't do anything. The numbers are low. But you now give them ART, antiretroviral treatment, and this now helps the immune system recover. Then they're like, oh, by the way, we have invaders. They start attacking the invaders and they overreact to this. And that's what actually brings about the symptoms. It's a very nice read up that's on Medscape. Just find some time to actually head over there and read up on IRIS. It's a very, very interesting thing to read up on. Now, in the last and the final question, a young mother storms your consultation room. I wonder why mothers are storming into consultation room. In the consultation room, panicking about a swelling on the head of a well-looking 5-year-old baby. She vehemently denies any history of trauma. On examination, the baby is active, febrile, and in no apparent distress. Write down your differential diagnosis. On further questioning, the mother swears her baby's head was perfectly well at birth, and she only noticed the swelling a day before. What is your most likely diagnosis? Write down 2 hematological parameters you would like to monitor with regard to your diagnosis. How would you manage this neonate? Interesting question, right? So here comes the answer. So the 2 things you should consider is, of course, a cephalohematoma, which is a subperiosteal hemorrhage, as well as a caput succedaneum, which is pretty much a diffuse edema that's going to be presenting as a dark swelling of the soft tissue. This tends to cross the suture lines, and it also crosses the midlines. So the fact that it didn't happen at birth, the caput succedaneum is usually present at birth. Then the cephalohematomas usually now develop after birth. So it's most likely that this person had a cephalohematoma. So you want to, of course, monitor your serum bilirubin as well as your FBC, where you look at your HB, you look at your RBC and your WBC in terms of anemias as well as infections. Now, how do you manage this neonate? So you reassure the mother that it will resolve with time. So you actually can have conservative management where you have observations. You can take skull x-rays or CT scans if there's any neurological symptoms that appear. you monitor the jaundice, or you monitor if there's any jaundice or any rising bilirubin levels. Then of course phototherapy can sometimes be used if there is some jaundice or rising bilirubin levels. Then if it continues to rise significantly in size and it does not resolve, then you can actually cover this child on prophylactic intravenous antibiotics. Then you can also perform spontaneous aspiration from this same cephalohematoma. So I really hope that helped you gain some light on pediatrics. If it did, drop a like and drop a comment. Show some support to the channel. My name is Dr. Moses Kazevu. It is exam week. Stay tuned for the next video. Today we have 2 videos that are going to be released. Until next time, bye-bye.